Hi, welcome to another episode of In Good Health with McLaren Macomb. I'm Toya Hankins. Today we're going to talk joint pain with orthopedic surgeon Dr. Michael Wagner. Then we're going to look at some of McLaren Macomb's contributions to the community. But first, we're going to talk with Dr. Albert Przybylski about your kids going back to school. Dr. Przybylski, welcome to In Good Health.
Thank you.
How are you today?
I am good.
Very good, very good. So we're going to talk about family health.
Okay.
And in particular, kids going back to school and, the things that come up health-wise regarding that. But first of all, let's talk about being a family physician. So you cover mom and dad and the kids, the whole gamut. Is that true?
That is true.
Okay.
From cradle to the grave,
right?
Right. We have 6-day-old neonates in the office, and our oldest current patient is 105.
Oh, wow.
And everything in between.
That's amazing. Now, how long have you been with a 105-year-old?
She has been with me the entirety of my career.
Really?
She met me during my residency, and this is year 22 for me, so quite a while.
Oh, my goodness. Yeah, that must feel really amazing.
She's our grandma.
Okay.
We ironically have 5 patients now in excess of 100, so centurions, and we have 6 coming in about 6 weeks.
Okay, that's amazing. That's really great.
They're amazing people.
What's the key to it?
Well, at my office, I have a board that I originally started with the kids.
Okay.
So newborns pictures, kindergarten, and on the top of the board it says Dr. P's Most Wanted. And as the kids go through the practice, they see their 5-year-old picture and they want their 10-year-old picture. And I have a couple of military kids who are now sending me their military pics and wedding pics, and they're on the board.
That's awesome.
I thought that, it doesn't take a whole lot of work just to be born, right? You're just born. But to be an elder takes a lot of work.
That's right.
So about 6 years ago, I started the oldies but goodie board. You got to be 85 or more to be on the board. And it took off like crazy.
Yeah.
The students that I train in my office, I share with a good number of them that what's consistent on that board is I only have one smoker on the board. They've never stopped moving, and they've stayed pretty healthy most of their life. They're not just up there by happenstance.
Wow.
So it's a message. People are coming to the practice and they see, and like, how do you get on that board?
Yeah.
And then I share with them, get to 85 and we'll put you there.
That's good stuff. My grandmother's 97, and for all intent and purpose, she's really healthy. So it's a blessing. I think that's awesome.
And Grandma's probably not a former smoker?
No. In fact, she was a gardener until she was like 87, when she was pushing her mower, and we stopped her, which might have been the worst thing we could have done, to slow her down. We should have let her keep going. From family to family, from year to year, are there ailments that you see consistent that pop up, in the spring? Is it cold season? Is it, what are the consistent ailments you see in your office?
Absolutely. As spring comes around, everybody who has any kind of seasonal allergies knows, Dr. P, I need my nose spray. Should I start my Claritin? They have all kinds of gadgets of things that they do. That's pretty unique. Once we see the tulips bud up, it's time to start preparing for your allergies because they're coming.
Right.
Summer, that kind of fades away by the Father's Day period, give or take. And you get a little reprieve about 6 to 8 weeks. And then ragweed, which showed itself a couple of weeks ago, starts allergies all over again. The sprays start, the antihistamine. Dr. P, could I have some steroids? They know the tricks. First frost usually eliminates most seasonal allergies. Okay. I always tell them, end of September, early October. And the second frost, you're usually good to go. Put your nose spray away until next year's tulips come up.
Okay.
So in the seasonal allergy, those are the patterns, and they've been going pretty true for all of my years of practice.
Okay. What about with the kids going back to school, being exposed to other children? What kinds of things do you see pop up?
Well, all the stuff we're used to seeing, because most of us have either had kids ourselves or around kids. It's now the second week of September, and I wouldn't need to know that by the calendar. It's just the volume of people in the office. So I refer to all the kids in the practice as furballs. So once the furballs get back to school, we all know what furballs do, right? They pick noses, they touch drinking fountains, banisters, they share gadgets and gadgets. It usually takes not but a week or two for us as adults, mom, dad, grandma, and grandpa, to start being exposed to common colds. The snotties, Dr. P, my throat's killing me, my ears are popping, what do you have? Most of it ends up being viral. and it is shared very easily in close proximity, and we see it in every office, peds and mine alike.
Wow. Okay. Yeah. And so you're seeing it crossing not just between the children, but also children giving it to the parents.
Of course.
Yeah.
I mean, they touch the silverware drawer, the refrigerator handle, the bathroom door, and even as a parent, I explain to my patients, most of my coughs, colds, illness don't come from the office, because when you wash your hand 50 times a day, that's difficult. But I go home as a father of 4, and they were touching the refrigerator handle, and I'm not as good at washing hands at home, thinking I don't need to, so there comes my cough, colds, etc.
Yeah. So would you say that's the most common thing you see when kids go back to school, or do you get a fair amount of pink eye and some of these other things that we see?
There's sporadic things that show up. Interestingly, I've had a couple cases of hand, foot, and mouth, which has a little funny sound to it. It sounds like a horse disease, but it's for the 7-year-old in the 2nd grade. It's a virus that kind of comes on pretty quickly. It's very contagious. You know, once one kid in practice in the classroom has it, you can plan on a number of other kids having the same thing.
What does it look like? I mean, what's hand, foot, mouth?
They slough off their skin. They look like a snake on the palms of their hands and the soles of their feet. It's usually 1 hand, 2 feet, or vice versa. And then the back of the throat just is on fire for a couple days.
Wow.
It's very self-limiting. It looks worse than it really is. It actually has a very funny name if you're interested. The virus is called the Coxsackie bee. I don't know who came up with that one, but that's the guilty party for hand, foot, and mouth. Most adults have had it, so we are immune, so the teachers are unaffected, and principals and counselors, but it goes through the classroom like wildfire when one of them gets it.
What about ringworm? I remember being younger, and ringworm was a thing, you know. Do you see much of that still?
Ringworm's still a thing.
Okay.
Yeah. The people who hate it the most are the wrestlers, because then they're forbidden from participating until it's resolved, and they come into my office on Monday, and they want it gone by Wednesday when their match is, and I remind them that can't happen. Very contagious. And again, we go back to the fur balls and their activities with the headlocks during recess and in the cafeteria. So they do all the kind of things we're not going to do here in the office. It's simply treated, of course, and self-limiting. We get it taken care of, but it's certainly a seasonal thing. When it's hot out, again, close activities, the things that they do to just fester that fungus among us, as I call it for patients.
So, Dr. P, do you see a difference in the ailments that you come across from the little bitty kids to the junior high and high school kids, and maybe even the older kids who are off at college?
We do. If we took as just maybe a age mile marker of about 14, which puts most kids now jumping into high school, they, of course, have different habits. We're hoping in high school they're not now picking the nose like the 6-year-old was, and they have maybe a little bit different habits. But some of the things they do that are in commonality is cell phones. Right. So if I cough into my hand and I'm not washing it and I have to show you this thing you just have to see, and of course you click it, and now you grab your whatever meal and put it right into your mouth. You just took care of what you have. Mono, we all know the kissing disease, right? Well, there's a little bit of truth to that. So a little bit of saliva exchange to get that viral infection going. And you can watch mono go throughout a high school in pretty rapid numbers. They are also pretty poor eaters. They're really poor sleepers. They have some of the bad habits that we're starting to see, which is certainly impacting their immune system. And the slightest of little something that comes along and nabs onto them, and then they're in my office.
Strep throat, maybe?
Strep throats and mono, big old tonsils, and fever and temperature. And, of course, they've usually waited a week too long. They haven't told mom or dad, right? A little different than the 7-year-old. You monitor 7-year-old. 17-year-old doesn't usually admit much till they're near death.
Right.
Then they come and see me, and they want to be healed, right? It seems every 2nd or 3rd year in the college world, same thing holds. We put them together in mainly a dormitory, and it hasn't been too long you haven't heard about measles outbreaks, and it's a bunch of 20-year-olds on a college campus.
Wow.
Who also don't eat very well, who have some crazy nights. They have poor sleep patterns, and the virus is allowed to have its way with them. And again, it just goes throughout. It just shows you when we come together, we expose ourselves to things much more so than when it's June and July and we're golfing and tennis and we're outside and we're not near each other. It's like a switch that gets held, and then the bugs take advantage of that.
Wow, we have to safeguard ourselves for others and for ourselves.
Correct.
Like keep our hands washed and things.
Correct.
So what advice would you give a parent, how do you manage it? How would a parent with a kid just out, on their own, into everything, mingling with other children. How do you keep it under control?
Well, you do your best as a parent to try and educate your kid. Keep in mind you're talking sometimes to a 6-year-old and an 8-year-old.
Right.
It goes in this ear and out the other. Hand washing is key. By far, it's what they come in contact with that's going to expose them.
Sneezing into the arm was probably one of the best campaigns around.
And still coughing into the arm.
Yeah, coughing into the arm.
Keeping everything on your sleeve because no one should be walking up to you on a regular basis.
Right.
Good nutrition is key. I mean, that's one thing that parents certainly are in control of. If your son or daughter is existing on, goldfish, chicken nuggets, and donuts, they're probably going to find themselves having a lessened immune system.
Okay.
So the old fruits and veggies, like Grandma told us, is probably still a pretty wise idea.
Apple a day.
Apple a day keeps me away. Oranges and orange juice for a little vitamin C push works. But hand hygiene, and maybe keeping your own personal space during school time, which is really hard to tell a 6-year-old, but that would work.
And so hand sanitizer, is it really a good thing for kids to carry on their key ring, or adults, for all of us to keep by our side?
I believe so.
Okay.
There's lots of medical arguments amongst us about us creating super bugs by doing what we're doing. But at the time when you have a 7-year-old whose fever is 100, you're not usually caring about the super bug. You just want this cold that you wish wasn't here to be gone, or the ear infection that they're dealing with. So absolutely with the soaps and alcoholic detergents, very good.
Go for it.
Yep.
Yes. Okay. Thanks for being here with us today, Dr. P.
You're welcome.
Appreciate your insights, and feel better.
Will do.
To make an appointment with a family physician, visit mclaren.org/Macomb appointments.
Now let's see how McLaren Macomb is benefiting our community.
McLaren Macomb believes in actively being involved in our community. We feel it is important to understand the community that we serve and to build relationships with them and really have a pulse on what their needs are. So we sponsor activities, we get engaged in activities, our employees participate in different events throughout the county to really show our partnerships and build those relationships with the community. Ride Richmond was an inaugural event created by McLaren Macomb in a beautiful Me. It was a family, fun, focused bike event where we had 3 different lengths and really encouraged the community to be physically active for that morning. The Health and Safety Fair was in Shelby Township. We had many different service lines from the hospital represented to share with the community the services that we offer within the hospital and to get acquainted with the community. Being actively engaged in our community, establishing that community outreach does help us to build a relationship with our community members, to understand their needs, to understand who they are, and how we can best adopt our services to help them. At McLaren Macomb, we have a Diversity and Inclusion Council that we created about 3 years ago. Again, as we saw in the community, as we did our community health needs assessment, that the demographics of Macomb County was changing greatly. We felt it was really important to be able to meet the needs of our community. With that council, we have brought in a new interpretation device called MARTI that will interpret over 200 languages. It also provides sign language interpretation for our hearing impaired community. As part of an educational component to our diversity inclusion initiatives, we've created Culture and Cuisine, which is a monthly event that we do at the hospital for employees where we focus on a country or culture and create authentic meals from that culture for our employees to taste, and then we do some education about the country of origin. We are also out in Macomb County helping to carry those initiatives also into the community, such as we're part of Macomb Act. We do a lot of events with One Macomb. We do a student diversity summit with Macomb Community College, really trying to build awareness of the importance of inclusion and to make Macomb County a more welcoming community.
Welcome, Dr. Wagner.
Thank you for having me.
So we're going to talk a little bit about orthopedic surgery.
Yes, ma'am.
Okay, cool. Let's start with who your most common patient is.
My subspecialty is in hip and knee replacements. We call it adult reconstruction. So the majority of my patients are more elderly patients that are getting slowed down by time and overuse and pain in those achy joints.
Okay. All right. So pain and the achy joints are usually the indicators for them to come and see an orthopedic surgeon?
Most of the time, I am the second line of defense, if you will. Most people will start with their primary care physician, but everyone out there has a family member or friend that has similar types of symptoms that says, you have to go see so-and-so. My job is to keep people moving. So, joint replacement surgeons are a long-term career, if you will. We see the patients and hopefully can push them off and towards any surgical procedure for a long period of time, but we do what we can to kind of start low and build from there.
Okay. So what are some of the things that you find your patients start to feel initially? Like, is it arthritis or is it just a back pain or a hip pain? What will get the process started from a patient point of view?
Most likely it's they are able to do some activity, whether it be golf, long walks, tennis, you name it, that they're just unable to perform up to their normal comfort level or what they normally like to do. It can be associated with stiffness, inability to do certain activities, or one of the most frequent is obviously pain. It can tend to start localized in certain areas, but as time tends to do, it catches up with all of us and it becomes more global from there, most likely.
Okay. And so tell us a little bit about some of the newer technologies that you're using here at McLaren to assist with treating people who need your work.
Technology, as it is in almost every sector out there, is become a boon, if you will, in the orthopedics department. A saying that I like to say is that a robot or technology has never gone into a certain area and then been taken out of it, and that is true in orthopedics as well. Here at McLaren Macomb, we are lucky enough to have the Macoplasty technology, and to the untrained eye, it might not seem with much, but the way we can make our joint replacement procedures, particularly about the hip and the knee, last the longest is to put them in properly. Okay. That leads to better stability, better function, and through better function and form, we have better outcomes. Okay.
So the greatest benefit to the patient who might have robotic surgery is accuracy, or?
Too long in the orthopedics realm, we were placing everybody into the same box. If you had knee arthritis, you were placed into the knee arthritis box. And it probably took us longer to realize than we should have that we need to have a more individualized approach. And the robot allows us to do it. Down to a simple millimeter or simple degree, we can correct the deformity specific to that particular patient. Mm-hmm. Getting that leg straight, getting the knee moving, getting the hip moving are all ideal situations to get you back to your life, to your activities that make you you.
Okay. So then from a doctor's point of view, you're servicing your patient greater and providing a more specialized care. What else?
Well, the information that we put into the robot the robot's only as good as the information that we put into it. So it's still prudent that we recognize each deformity. And I had a trainer of mine that used to say there was the science of medicine and the art of medicine. And the art of medicine is, the reason we call it a practice. It's something we refine over years and years of our career, and the reason our training is so long. So by doing hundreds and thousands of these procedures, we can hopefully have the best outcomes for all of our patients.
Okay. What advice would you give all of our viewers who are growing older, to help them maintain a healthy back and knee and hip and things of that nature?
Well, it seems counterintuitive, but my number one thing that I always tell my patients is to keep moving. Mm-hmm. Oftentimes people think if they stop moving, they'll feel better, but it's a true if you don't use it, you'll lose it situation. In regards to the hips and knees, they are very much a wear and tear joint. So that when we get weakness through those joints, we tend to see them break down even quicker. By keeping the muscles that surround the joint strong, by keeping appropriate stretches and range of motions, is the number one thing we can do to improve joint health. The same could be said both before surgery and after any surgical procedure.
Okay. Does diet play a role in it all? in your area?
It does. There are some inflammatory foods, and a quick Google search will obviously tell you everything's going to be bad for you, but a healthy, balanced diet and a healthy weight will provide less stress across both the hips and knees. Every pound we're overweight is actually 5 pounds across the knee, so you can imagine those forces add up quickly.
What are some of the concerns that a prospective patient might have, as they are contemplating whether or not they want to go through with the surgery?
And it's very valid for patients to have some concerns because this is a major procedure, but it is also an elective procedure at the same time. We have a very refined approach to how we address hip and knee replacements in particular. People often are concerned that the pain will be unbearable or the recovery will be long and lots of work. And again, it goes back to setting a proper expectations for the patient. In regards to the pain, we take a multimodal pain approach with nerve blocks and local injections and oral anti-inflammatories and when needed, pain medications for a short duration of time. But as we continue to rehab, the knee acts like your knee again. And if you didn't need pain meds before, oftentimes after 6 weeks or so, we typically don't require any from there. The general overall concern is life doesn't stop. People have work, they have family, they have parties, they have holidays. So there will never be an ideal time to get your joint replacement done. But more often than not, I do have patients say, I wish I would have done it years ago. I don't like that approach to it because I don't like the woulda, coulda, shoulda game, but when it's right for you, you'll know. My philosophy is I will never ever tell a patient they have to have a joint replacement done. I'll tell you when it's an option, and you'll tell me when you're ready.
Doing the robotic surgery, does it result in quicker recovery times, or what other benefits would a patient see from this type of surgery?
Well, there are multiple procedures that we can use the robot for. In particular, the partial knee replacement has seen the absolute quickest return. It's a smaller incision, a shorter operative time, less bony work, less soft tissue stripping needed to perform the procedure. The vast majority of our partial knee replacements are going home as the same day of their surgery. Most walk into my office at 2 weeks with no crutches, canes, or walkers. Most are back at their jobs inside of a month. My quickest is I had a patient water skiing at 3 weeks. It might have caused a little chest pains for me, but he was happy.
So aside from backs and knees and hips, what other areas do you work on? Is it fingers and toes and...
I am also on the trauma schedule here at the trauma call schedule here at McLaren, so I do a lot of fracture care. Unfortunately, we see way too many elderly hip fractures, but there's no use worrying about what's done is done. All we can do is move forward with the best treatment options possible. Ankle fractures, general hand procedures, and I do a large percentage of shoulder surgeries as well, both arthroscopic and arthroplasty procedures.
Okay. I had a personal incident occur where I fell, and it just showed me how really amazing the body is. I fell, and it was a pretty, significant blow to the knee. Yes, high heels. No friend of mine.
I don't know how you do it.
And my knee started to grow extra bone, and it was really interesting. So I had to go in, and they had to remove the extra bone. So I think my knee thought that it was broken, perhaps, and was starting to heal itself.
The body only knows how to do so many things, and one of the things it does do well is form bone. Bone is actually the only tissue in the body that heals with more bone. Everything else heals with a scar.
Okay.
So with bad injuries to muscles or around the bone itself, no different than you would see a bone spur around arthritis. Every now and then the body says, hey, I'm going to throw some bone down here. And unfortunately, it's kind of like a snowball rolling down a hill. The body sees more bone, sees it as more injury, so it lays down more bone, and it can be a very vicious cycle.
Right. Yeah, I was really relieved to have that taken care of.
Real weight off your chest.
Is it likely that a patient, after visiting your department and having surgery, will be able to return to their full activity?
Managing expectations after a joint replacement is a very important part of my role. I like to tell patients, I'm going to cause you more pain before I cause you less. Too often in orthopedics, we were quick to pat ourselves on the back if the knee came straight and bent back appropriately. But there were a lot of people that just kept thinking, man, I've got a partial knee or a total knee. By managing those expectations, we set a more appropriate reality for these patients. And with time, the vast majority of my patients anyways do get back to doing those activities that make them new. I have no problems with golfing or tennis, or pickleball seems to be all the rage these days. You will occasionally hear people say you cannot kneel or run or jump on a knee replacement or hip replacement. I don't have any restrictions for you. My job is to get you moving again. And if those are the things that truly make you you and that you enjoy, perhaps you might wear your knee or hip out a little bit quicker, but you'll live life a little more fully as long as I don't give you any restrictions.
That sounds fantastic. Dr. Wagner's the doctor to see, huh?
I'm happy to help in any way I can, but our role has been such a team-based approach, and I am just one member of that team, so I couldn't do it without the joint program that we have here, the McLaren Macomb, and I think we do a pretty good job in that regard.
That's fantastic. Thanks so much.
Thank you.
To learn more, visit mclaren.org/MACO.
Thank you for joining us for another episode of In Good Health with McLaren Macomb. We'll see you next time.
To watch this episode again, visit mclaren.org/MacombBlog.